Hypoparathyroidism, mechanism of disease. Hypoparathyroidism is a rare, complex endocrine deficiency disorder involving the parathyroid glands and is characterized by absent or abnormally low levels of parathyroid hormone, PTH, in the bloodstream, causing low serum calcium levels and elevated serum phosphate levels. Despite the seriousness of the disorder, there are no formal guidelines on how to treat hypoparathyroidism, and current strategies are focused in large part on symptom management rather than treating the underlying cause. The most common cause of hypoparathyroidism is the inadvertent removal or irreversible damage to the parathyroid glands, usually to their blood supply during thyroidectomy, parathyroidectomy, or radical neck dissection. Several other non-surgical causes of hypoparathyroidism include inherited disorders such as DiGeorge syndrome and other mutations, autoimmune diseases, other disorders affecting either the function or viability of the glands such as tumor infiltration or the imbalance of certain metals, as well as unknown causes known as idiopathic hypoparathyroidism. Calcium plays a critical role in maintaining the body's normal function. The calcium sensing receptor, CASR, has been found in a host of tissues throughout the body, including the parathyroid glands, brain, bones, heart, and kidneys. The CASRs in parathyroid glands, kidneys, bones, and the GI tract play a vital role in calcium homeostasis. In other cells, calcium plays an essential role in such activities as muscle and neuronal function and cardiac contractility. Swings in calcium concentration may generate various symptoms related to these functions. In normal physiology, PTH is released by the parathyroid glands, maintaining the homeostatic balance of serum calcium and phosphate. Parathyroid cells have extracellular calcium-sensing receptors, which detect changes in serum calcium levels. This results in more PTH secretion when serum calcium levels drop and less secretion when calcium levels are restored. The actual homeostatic effects of PTH occur primarily in the bones, kidneys, and through intestinal absorption. Bone tissue formation and resorption are part of a process through which calcium, phosphate, and other minerals are stored and released. PTH stimulates bone resorption, and consequently the release of calcium and phosphate into the bloodstream. In the kidney, PTH stimulates renal reabsorption, thereby retaining more calcium in the blood, and PTH also promotes phosphate excretion. PTH also enhances the conversion of endogenous vitamin D to its active vitamin D metabolite, which then increases the absorption of calcium and phosphate in the intestines. When PTH secretion is compromised, bone cannot be adequately resorbed in response to low levels of serum calcium. Bone formation then outpaces bone resorption, which can additionally cause abnormal bone formation, hypermineralization, or adynamic bone disease. When PTH is absent or low in concentration, the kidneys are unable to reabsorb calcium and retain the proper levels of calcium in the bloodstream. This causes inappropriate amounts of calcium to be eliminated in the urine. Additional negative effects due to excretion include nephrocalcinosis, kidney stones, or even chronic kidney disease. The lack of phosphate excretion in the kidneys can lead to hyperphosphatemia, a condition sometimes associated with the deposition of calcium phosphate complexes in soft tissues, which can result in negative sequelae in the affected organs. Insufficient PTH also means that the enhanced vitamin D conversion does not occur, thereby making the intestinal absorption of calcium less effective. The symptoms of the resulting hypocalcemia and hyperphosphatemia can be widespread. Neuromuscular symptoms are typically the most prominent, including muscle cramping, twitching, tetany, and spasms, including laryngospasm or bronchospasm, numbness or tingling, paresthesias, of the mouth area and extremities, seizures. Cardiac function too may be affected with prolonged QT interval and/or arrhythmia. In rare cases, depressed systolic function and heart failure can result. Other complications include premature cataracts, pseudotumor cerebri, when the pressure inside one's skull, known as intracranial pressure, increases, calcifications of basal ganglia, brain tissue. Patients also report other symptoms like difficulty in concentrating or brain fog. Psychiatric complications. The current goal of hypoparathyroidism therapy is to control symptoms while minimizing complications. This can include taking oral calcium and vitamin D metabolites and analogs. However, increased intake of calcium and vitamin D metabolite can lead to worsening of hypercalciuria and the associated adverse effects on the renal and central nervous systems. Perhaps because it is a rare condition, hypoparathyroidism has only recently begun to capture the focus of the medical research community. Hypoparathyroidism results in hypocalcemia, which in turn affects many organ systems directly. But it is also a complex disorder that, when managed with high doses of calcium or vitamin D metabolites and analogs, may indirectly cause other serious health consequences. Currently, symptoms may be managed, but the underlying condition, such as the absence of appropriate levels of PTH, is not treated. In fact, hypoparathyroidism is the only classical endocrine deficiency that does not have a replacement therapy available.